Hello, it's good afternoon to COVID scientists and warriors. I am Dr. Subhash Hira, a medical doctor of infectious diseases and a public health scientist. I am the moderator of webinar learning series that is launched by the Global COVID Network. This global network is launched because COVID 19 is a pandemic, and the best way to respond to it is by bringing the global actors together. Thus, Sambodhi Research and Communication Organization, Indian Social Responsibility Network of New Delhi, and the University of Washington, Seattle have co-sponsored this global network to foster South-South collaboration and partnerships to share lessons of COVID. Mr. Sudhanshu Malhotra of Sambodhi has an important announcement to make. So, Mr. Sudhanshu ji, please come over and let participants hear your announcement.
Thank you so much, Dr. Hira, and good afternoon, good evening, and a very warm welcome to our panelists and our participants and our viewers on social media. I'll just like to take a minute to announce the launch of our Global COVID Network microsite. This is a platform that we'll be using as a repository for our learnings from this event, this series of events, and any other events we hope to have in the future on the network. And we'll also be using this platform as a knowledge hub for best practices, learnings, and experiences, which we hope to share with the public at large and globally as well. And I'm looking forward to this extremely well experienced, rich discussion between these experienced panelists. Thank you so much.
Since the microsite has been launched and is active with earlier webinars, I will be very brief to recap the second webinar held on 5th of May 2020. Dr. Zhao of China CDC presented the Wuhan province experience and of COVID emergence, among other things. 2 months of total lockdown with 45,000 infections and 3,500 deaths with a fatality rate of 6.5%. Wuhan province has been reopened for the past 3 months, and COVID cases have now settled down to 0 new cases in the last 14 days. China has not seen a single case of reinfection so far. Mr. Jaimrugh of IIT Bombay, he discussed several models that are being used to estimate COVID trajectory. He suggested adding some variables to infectious disease model, namely RO equal to beta CD, and to several mathematical models to make them more realistic in terms of predicting the trajectory of COVID. Namely, the variables such as economical and travel integration of COVID-free areas that are linked with high COVID prevalence areas. Let me take a minute here to explain the infectious disease formula that we have been discussing so frequently, that is RO equal to beta CD, and it is used to calculate the speed of spread of an infectious disease and has been used successfully since 1980s. The slide here being projected, it shows the speed of spread of childhood infections such as rubella with an RO of 5.5, or mumps with RO of 7, or measles with RO of 15. The yellow dot represents an index case that infects number of other contacts around them as shown as red dots. Whereas the new world infectious diseases such as Ebola, SARS, and COVID, they show RO rates of 2, 3.5, and 2.5 respectively. It is only when RO rate falls below 1, such as MERS, which is shown on the left-hand top left circle, where the RO rate of 0.75, that the MERS epidemic it died off after several spurts in the Middle East countries during 2014 and 2017. The second circle on the top row on the slide is for common cold influenza, which shows that for every yellow dot of an index case, a contact, 1.5 contact cases get infected. The third one is Ebola, where for every index case, 2 get infected. And for COVID, it is for every 1 index case, 2.5 individuals get infected, while for SARS, it is 3.5 contact cases that get infected during the total period of its transmissibility. In other words, each of these viruses move with different speeds depending on their own characteristics. The third webinar today is titled Country Responses to the COVID Epidemic and the Diagnostics and Testing. Our first speaker is Dr. Vinay Sahasrabuddhe. He has PhD from Mumbai University. He's presently a member of Parliament of the Upper House and President of the Indian Council of Cultural Relations in New Delhi, which is an autonomous institution of the Ministry of External Affairs of the Government of India. He is also the Vice Chair of Indian Social Responsibility Network. He will present the country responses of India to COVID. Towards the end of his lecture, he will answer a few questions and leave at 6 p.m. because of some national commitments. I request Vinayji kindly take over the mic. Thank you so much.
Thank you very much. Thank you, Dr. Subhash Hira. Also, all the other dignitaries present over here, Professor Sudhanshu, Dr. Sarman Singh, Dr. Kaur from Cambodia, and all other very renowned experts in this field and other participants. It's a pleasure and it's an honor as well to be participating in this webinar, wherein I would try to share my understanding of Indian approach towards this particular pandemic. It may not be a governmental approach essentially, but essentially how the society in India and how our cultural moorings, especially, in a way, promote this kind of approach towards the pandemic. Basically, I mean, as you're aware that India was very quick in responding to the pandemic. Major policy decision of the Prime Minister to declare the national lockdown on the 21st of March 2020, I think remained a singularly important decision, which definitely helped India halting the spread of this particular pandemic, especially in the hinterland and in the interiors of rural India, especially. This was followed by effective communication by national leaders. The Prime Minister himself has more than 4 times addressed the nation. In fact, today evening also, he is going to address the entire country through a television channel. Lockdown had saved many infections from happening. Currently, only 66,000 Indians have tested positive out of 13 lakh tests done for the corona so far. Rapid response to the pandemic has also contributed to whatever success India has achieved. Number one is the local production of N95 masks and protective gowns. I must also mention over here that the Prime Minister and the leaders in the government have been insisting repeatedly that it need not be a very structured mask as such, but even a simple piece of linen one can use as a face cover, as what we have been describing it. And therefore, popularly, people in India have been accustomed to use some kind of a piece of cloth during the uh, hot sun, especially during the summer, and therefore this particular habit also has come handy in use of the masks or similar face covers. We also have imported certain masks, especially the N95 mask initially, but today in most villages also and in other urban areas, self-help groups essentially run by women have promoted the manufacturing of masks, which are homemade kind of face covers, and that has become quite a popular movement as such. Indian research institutes have started producing rapid COVID testing kits, and they are also now abundantly available, which was not the case at the initial stage. Massive scale up of hospitals and quarantine facilities, including the Indian Railways, for example, have segregated some 20,000 of its coaches as facilities for hosting the corona patients or suspected corona patients who require to be quarantined for a while. The success indicator, if at all that is to be focused, then the minimal deaths due to COVID is one of the very significant indicator. Although I mean, recently there is a little bit of a spurt in it, but I'm sure it will be arrested in the immediate future. We also have scaled up the supply of chloroquine and other 150 medicines, not only within India, but also whosoever required this kind of a medicine and help from India, we have extended it, including the United States and other countries as well. We have also remarkably shown our readiness of Indian vaccine production companies to undertake large-scale production of COVID vaccines when they were designed. Another important factor is the role played by and the role that is being played by Ayush Ministry, which is a dedicated ministry for traditional Indian medicinal systems, including Ayurveda, Yoga, Unani, and Siddha, and also homeopathy. And all these pathis, in a way, have come together. All the practitioners in these different disciplines of medical science have come together, and they are also helping the government in a very significant manner. I believe one of the most important factor to be noted over here is that even though India is a country where there are different levels of literacy and education is also perhaps not made deeper inroads into the rural areas and the tribal areas as well, I believe very significant that there isn't any kind of a mass creation of any panic or a paranoia kind of a situation. And people have looked at the situation that is emerging out of this pandemic in a very dignified manner, and they are taking all the factors into consideration, and thereafter they are taking up steps. There is some kind of a migration that is happening due to the governmental efforts of providing vehicles, including dedicated train services. It is also being regulated very remarkably, I would say. And now that the third lockdown period is about to come to a close in another 4-5 days, I'm sure the nation is preparing itself with the help of the government for opening up. And as what the Prime Minister had indicated, that we are here to protect lives, but we are also here to provide livelihood opportunities in requisite numbers to those who are likely to be facing unemployment and issues about livelihood as well. And therefore, a kind of a calibrated approach where a balance is being struck in a very planned manner, that is something which definitely one can say about the Indian approach towards the handling of the pandemic. I must also mention over here that along with the government, which is the central government at the federal level, and all the state governments and all the local self-government bodies have also very significantly contributed in the efforts to arrest the pandemic in the cities, in smaller towns, and at times even rural areas, although essentially large rural areas of India today are free from this pandemic so far. And I believe, touch wood, this situation continues, and we don't allow the cities to export this particular disease and the virus to the hinterland, to the rural areas as well. So this is something very significant about the Indian approach. As a student of social sciences, if I may say so, that while we have been insisting on all the three basic messages which the government tried to communicate to the people in a very strong manner and very aggressively, very emphatically. But there is a kind of other socio-cultural message also that we have been communicating to the people, if not very formally, but through informal conversations. We have to be sensitive towards each other. We have to understand that we are fighting against this disease and not fighting against those who are affected by this disease. And therefore, physical distance, yes, but a complete no to any kind of emotional or psychological distance. But while you must cover your faces, you must keep your hearts and your minds open and receptive. Because this is not something which we can deal with closed hearts and some kind of not so very receptive minds, because people are facing different kinds of situations. Those who are urban dwellers, they are facing different challenges. Those who are in forest areas, they are facing different challenges. Those who are salaried people, their challenges are different. But those who are daily wage earners, their challenges are different. And therefore, one size may not fit all. And therefore, our minds and hearts will have to be kept open. Our antennas will have to be remaining very, very sharp to the sensibilities of those who are the disadvantaged and the deprived sections of the society. So that has been the second message, very powerfully given. The third, for personal hygiene and personal care, we have to wash hands regularly. But that doesn't mean that we can wash off our hands towards the responsibilities that we shoulder as a responsible citizen. And therefore, this is also very, very required. And with that approach, I believe people in India have observed the protocols have, generally speaking, I would say, accepted whatever was appealed to them by the Prime Minister and by other government leaders also. And this is something very, very remarkable in a country like India, where there are many tensions within the society, within groups, within communities. And even then, I think India has established that unitedly we can very resolutely conduct this fight against the corona or the COVID-19. Three significant points I will make, and within a minute I will put a full stop to my presentation. Firstly, we have, in a way, realized the importance of traditional lifestyle, including Ayurveda and other things, but whatever daily routine that has normally, that was normally prescribed in an Indian family situation, I think that is coming to our help, and that has added to our ability to face this kind of a health hazard as well, or challenge of the health hazard. It also has a underlying message as to balancing between our individuality and our collectivism. Because in many countries, societies are ultra individualistic. There, people are feeling like they are left alone, they are isolated, they are not connected with each other. In India, for example, thanks to the efforts of the Prime Minister, we try to give this essential message that nobody is alone and nobody is isolated. We are all together. And there were many symbolic kind of collective actions that were taken up. But collectivism handled in a very individualistic manner in that sense. And therefore, this is again very remarkable about the way India has handled the pandemic. And thirdly, while like in several other countries, in India also, India and Indian society is always in a celebratory mood, and there are huge number of festivals and things like social, cultural, and religious celebrations. But today, for example, Indian society has decided that instead of becoming more and more extrovert, these are the times to look within. And therefore, this is an area, this is an occasion where most of us, I believe so, have turned the searchlight inward, and which is why, in the light of that inwardly turned searchlight, I think we have been able to take a few steps very resolutely but very successfully. Again, reminding all our people in the country and elsewhere also that essential message of India is that of the world is one family, which is Vasudhaiva Kutumbakam, which has rushed to our help in these hours of a trying and testing time. Thank you very much.
Thank you, Honorable Vinayji, for an excellent lecture. There have been a lot of congratulatory messages from Tripura, Haryana, Maharashtra, and other states congratulating you for a very excellent lecture, especially also evoking the traditional contents of the Indian responses. There are also many questions, but just two questions that I thought were repeated by several participants, and those are relating to overcrowding in Mumbai hospitals as well as opening up of alcohol shops in Mumbai and several other cities in India, and the concerns that participants have that these things in an epidemic situation do not do well. So over to Vinayji for your reaction, sir.
Well, I think it doesn't require understanding the rocket science to understand the difficulty in balancing out between lives and livelihood. I mean, that is a very difficult kind of a choice after all, and you cannot be entirely for saving lives and remaining unmindful of livelihood, or on the other hand, excessively underscoring the element of saving livelihood, come what may. The situation is insofar as saving lives are concerned. So you have to balance it out, and in our efforts to balance it out, maybe certain government agencies decided to open up the liquor shops, and then that was also later on handled very imaginatively. Nowadays, many state governments have decided to have it home delivered, and therefore, I think overcrowding in front of liquor shops is being avoided. Certain reforms are definitely being introduced. Insofar as overcrowding in Mumbai hospitals is concerned, Mumbai is a city of perennial overcrowding. So, while this is really very tragic and it pains our hearts, but I think the burden of population that, or the weight of population that we have been facing for maybe several decades eventually also requires to be taken into consideration.
Thank you, Vinayji. There are many more congratulatory messages on the Facebook and YouTube platforms, specifically from Shalini ji, Professor Ragini Garg, Mr. Shankar Gumaste of Seva Bharati, Sangamitra ji, and others who have congratulated you for clearly listing all the national responses to COVID and seem to have slowed down the spread of COVID and certainly has contained the case fatality rate below 3% in India. It's all about time for it's getting 6 o'clock that you have to leave for national commitment. And so on behalf of the global COVID network, it's a big thank you, sir, Vinayji, to you.
It was pleasure
for
interacting
being
with you
here.
all, and my sincere sense of gratitude towards each one and everyone. Thank you.
Thank you so much. Our second speaker is Dr. Por He is Deputy Director of National Institute of Public Health in Phnom Phen, Cambodia. He will speak about country responses of Cambodia that have been considered fairly important in terms of having contained the epidemic within a record time.
Thank you very much, Subha, for your introduction, and thank you very much for inviting me to join this interesting webinar. And also good, how I say, good evening also over there. Good evening, everyone. Let me start my two slides first about Cambodia. How can I share the slide? I share the screen, right?
Yes, doctor. If you just share your screen, we'll be able to. Yes.
Is that okay now?
Yes, sir.
Okay. So so I will go through the slide, and if necessary, later on we can discuss in more details. Before moving to the preparedness and response to COVID-19 in Cambodia, let me also briefly share two slides about the basic of SARS-CoV-2 transmission. Just to highlight that from infected person through coughing, sneezing, and breathing and other like talking, then the droplets can get out from that person and can land directly in nose, mouth, eyes, and possibly lungs of the other people. And the other way around, it's possibly that if they cannot land directly on another person, it can also fall on surface or any object that the other people can touch and can get infected. And there is also a small evidence around another possible way of transmission is through aerosol, for which the droplet becomes smaller and spread in the air, which is roughly less than 5 microgram. And that is only happening in specific circumstances or setting, for instance, many medical procedure in the ICU room. So just to highlight that for the first intervention, perhaps the most important we can highlight is the face mask. This is a very important one, and Cambodia have took that seriously since the very beginning of the epidemic, the outbreak. So the Prime Minister have announced publicly that we have to put the face mask. It does not mean that the mask, the surgical mask or any other mask, but the face mask. And in Cambodia, we have a traditional Khmer towel. We call it kroma. It's also recommended to be used for any person who feel that they are sick or having common cold or cough, have to cover their face. And then the other way, it's easy to talk about the prevention for the first way of direct transmission is to have the physical distancing or possibly combined with the personal protection equipment or exposure. And then for the surface and object contact, the easy measure and very commonly known is the hygiene, mainly hand hygiene by washing hand properly, as Dr. Said at the moment. And of course, for aerosol, it's in particular circumstances like in ICU, of course, the healthcare provider working in that area had to symptomatic throughout the period since the infection started. So 122, of which 120 already cured. Only 2 are still under follow-up. So no one died. And talking about the test, we have done over 14,000 tests. It's approximately about 12 or 13,000 people tested. And if we calculate per million population, we got like 800 something, over 800 tests per million. This is quite average testing rate as compared to other country, and the global average around 500, but certainly not as high as other neighboring country like in Singapore, Vietnam, Thailand. So when we see positive, but then suspected case, the one that we have to conduct the testing and also contact tracing, is one that defined by K definition, and this K definition have evolved over time. Very strict definition in very beginning, very narrow, to be a very large and broad definition to allow more possibility to test and to explore or to try to buy possible COVID transmission. We strictly follow WHO, and WHO have defined 4 scenarios. One is the country with no cases. Second, the country with a few cases, mainly import, and then cluster, and then the large transmission. So Cambodian have gone through alert, and then we reactivate or we enhance, we scale up the existing emergency response mechanism we have, including rapid response teams, and we have all the sentinel surveillance sites and so on, so on. And then we also have created the so-called National Committee to Fight COVID-19 chaired by our Prime Minister. It's a top decision maker, and there are many other subsequent multi-sectorial working group and task force, including a training task force for which I'm in that group. And then we at the same time also enhance the education, community education and re-communication about the COVID-19, including development of many educational tools, communication strategies, and disseminate country-wide through many available means, including media and Facebook, etc., and also telephone. So every time we call, there is a message before we get the answer. There is an alert that be careful, be reminded with the COVID-19 and so on, take your personal protection measure, something like that. And then the one that I think is critical to the control of the and since the very beginning, even before we identify the case, and we also have quite a very effective contact tracing for many reasons, including the fact that we have also involved the military and also police intelligence to identify the contact person, because the contact tracing is the most difficult work that the health people or the public health people cannot do it alone. So normally we follow WHO criteria. For confirmed care, we isolate and we send them to the hospital for follow-up care and treatment. And for suspected case or any contact person with the confirmed case, we also isolate them or put them in quarantine and then test and screen them for symptom. Once symptom happen, we also send them for the follow-up in the hospital. At the same time, we also strengthen and expand case management services in public hospital, mainly at the provincial hospital, including infrastructure, material, human resources. More importantly, the government have decided to give cash incentive to frontline workers and those who are exposed to the infection or the HIV, their work are exposed to the HIV, to the COVID-19, sorry. So it's around $40 per day. It's already like 3 times more than their salary. So then at the same time, the government also took many public health and administrative measures to ensure social, or we can say a physical distancing. and also a special plan to manage migrant workers returning from abroad. Why? Because the migrant worker is considered as one potential source that lead to community transmission that may be also spread around and lost control way. That's why we took that group as more seriously and as a priority risky group. So now I would like to show a summary of the flow chart of our case identification and contact tracing. So starting from a general mechanism to screen suspected case, and we also have some additional mechanism if there is any particular suspicion in some area for which it does not fall into definition, we still also have to do a screening, and both mechanisms can allow us to identify suspect case. As soon as we identify suspect case, we isolate them or put them in quarantine depending whether they are symptomatic or not. And then we immediately collect the specimen, the sample, and then do the testing. At the same time, there are also some other group that is a priority or risky group also ask for the test, including those who are requiring the certificate to go back home for the foreigners. And then when the test result negative, but then these people having a history or contact with the confirmed case, we still put them under the follow-up in the quarantine for 14 days. Within this 14 days, as soon as they becoming symptomatic, we do the test. If otherwise, we only do 2 tests at the end, last 48 hours. And if not, then we can release them. And for the negative without any contact history, we can release them. And for positive, we isolate, we follow up, and then we send them for the care and treatment in the isolation area in the hospital. And then we conduct in-depth interview with the case, the patient, and also other possible source of information, including telephone tracking, and also camera, and so on, to identify and to trace the contact person. And this had to be done within 48 hours after the test is being confirmed. And then based on that fact, we build a list of contact person for whom we also have to consider as a suspected case, and also the same measure will be taken as a suspected case. So along this period, we introduce 4 forms. The form 1 is the form for screening to look for suspected case. Form 2 is the laboratory testing form. Form 3 is the follow-up form for suspected case. And form 4 is the case reporting and contact tracing form. And then the 5 is about the list of contact person for whom we have to take some measure. And these are the few listed public health and administration measure to ensure physical distancing. So in Cambodia, so far we haven't decided to put the country in lockdown for the whole country, but we have decided a couple of measures depending on the risk to ensure physical distancing. So the first one that the government, the Prime Minister had decided to close schools, all level of schools, starting first in Siem Reap town where we found the first case, and then to over the country. At the same time, schools are encouraged to adopt distance and e-learning methods instead of face-to-face. And then all the social events which have more people gathering, more than 10 people, for instance, including concert, wedding, reception, sport event, bar, karaoke, casino are closed. But the government still allow market and restaurant to open. And to control big movement of people, especially a factory worker during the Khmer New Year holiday in April, the government decided to apply no holiday policy to employees and the government officials. It means that they have to work during the Khmer New Year public holidays from 13 to 16 April. And at the same time, the government also banned of travel across province, with exception for good transporter, armed forces and civil servants traveling to work for the COVID. The other are not allowed to travel across province between during the period of the Khmer New Year as well, from 10 to 16 April. And last but not least, is the measure to manage the migrant worker returning from abroad, mainly from Thailand. Although the border between Cambodia and Thailand is officially closed, but many Cambodian migrant workers who work in Thailand, when all the shop, restaurant, and many business closed over there, they have nothing to do. They decided to go back home, to come back home, and then the government still allowed them to enter. And then we decided to make a plan to manage these people, to minimize or to mitigate the risk. So this is the flow chart to explain how we manage these people. So we have first level at the border level, we have a screening, border screening points. So if people found to have fever, we immediately send them to the quarantine level 2 at the border. Otherwise, we let them go to province with a arranged transport, not private transport, a special arranged transport, to send them to the screening point at the provincial level. There they screen for symptom again, and if no symptom, they let them go again to the district. And then if they have symptom, then there at the provincial level, there is also a quarantine level 2 at the provincial, quarantine center level 2 at the provincial level. And then some additional screening tool can be done for people who have no symptom after screening at the provincial level, and some no additional screening depending on the ability and affordability of the local district. The people can be sent to quarantine center 1, level 1 at district level. And then the last one, for those who have nothing, still also are asked to be in home quarantine for 14 days. So you see this measure is very strict, and it's involved not only the health personnel, but also local authority, district, armed forces, and police as well, to ensure this is done correctly. So this is the end of my presentation about Cambodia. I think the diagnostic I will skip, because I think Dr. Sarman Singh, he will speak more about that. Maybe just a few words about the test.
Please go on.
From the medical perspective.
Yes.
From the medical perspective, just to know that there are not only disease-specific tests that people often talk about, the laboratory testing, but also there is a non-disease-specific test for which the test to allow diagnosis with the symptom and clinical sign. For instance, for COVID, we have quite a number of specific or common symptoms like fever and CT chest scan, for instance, but then not everywhere can be done in CT chest scan, but fever is becoming a very common one. But still, there's a lot of discussion whether there is a scientific proof. In Cambodia, to be honest, the fever scan doesn't help at all. And then we have the disease specific. We have the immunoassay. It means the test, we can call it a serological test, which include antigen based and antibody based. So antigen, it means that we can detect the viral protein in the body fluids, for instance, the upper respiratory fluid like sputum or swab of the fluid. And the other immunoassay is antibody based. It means that detect antiviral body in the blood. So when the infection happens, after some time, the infected people in the body start developing antibody, at that time we can have this test positive. So the other one, that is the standard test using today for the diagnostic of see that the non-disease specific doesn't work well in COVID-19. So this is only allow increasing the prevalence among the risk people for all the disease specific tests only. So I think this illustration is also interesting, but I think Dr. Sarman Singh will perhaps go through it, just to highlight that after the onset of the symptom, the viral RNA, or the one that respond to a molecular test, can start immediately and then reach the peak after some day. Here for illustration, I cannot put the number of days because there is not sufficient evidence to fix the date, how many days after that. But as you can see here, the red line, it's a viral antigen. It's showing quite similar time to the molecular test. It means antigen-based test can detect the virus at the same similar time as the molecular test. And then you see the two other line, it's about antibody test. It's very common to look for immunoglobulin M and immunoglobulin G as antibody. So normally immunoglobulin M develop first before immunoglobulin G, but G, when it develops, it can remain for so long. So based on this graph, it's just to say that the viral RNA or molecular test or antigen-based immunoassay is the test to look for active case or current infection, while antibody is more to look for past infection. So I go straight to the last slide. So by now, WHO, as we all know, that WHO only recommended diagnostic test for COVID-19 is a molecular test. But this test also have a lot of limitation as well. As you can see that they are increasing apart from false negative as a common limitation of this test, depending on the quality, not just of the test, but also the specimen collection, the time of specimen collection, and also the laboratory procedure. At the same time, molecular tests also recently show also there is a false positive. You can, maybe you hear already, like in the case in Korea, South Korea, they declare that the suspected reinfection becoming false positive because the particle of the virus or all the virus can also provide genetic and then can be detected by the molecular test and become positive as a false positive. So my last word is that for the test, certainly molecular test is very good. It's the only one we have so far. And antigen based, although it's not yet ready and still under evaluation, but it shows quite some potential for allowing more and larger test coverage. So if it will be reliable soon, made reliable soon, then it will become also an additional solution to the testing for the COVID-19. And for antibody, it's clear that it's to prove infection. So when infection is proved, it does not mean that the infection is still active. The patient, the positive patient can already cure or it's a past infection. So it's only served for public health or research purpose more than just for diagnostics. And at the same time, there are many companies also today try to address the limitation of the PCR limitation that is require sophisticated laboratory base to become a test that can be done near point of care. Like for instance, recently that the special cartridge for gene experts. So that's all of my presentation. Thank you very much.
Thank you, Dr. Paul, for an excellent lecture. There are lots and lots of questions from our participants, both who are actively joined on the Zoom and several thousand participants who are watching this live on Facebook and Twitter platforms. So the questions have just kept on pouring in. But apart from the participants congratulating Cambodia for containing COVID-19 epidemic so well, such that there are no new cases since April 24, 2020, there is a burning question that has repeatedly appeared, and then asking you to explain how the restaurants have remained opened in Cambodia during the epidemic, and particularly that they are asking for how the physical space has been redone in these restaurants so that there has been no new infections happening there. And if you can add some details about when the schools and colleges and institutions of higher learning will open up in Cambodia. So with that, I ask you to please respond.
Not officially representing the government. So sometimes it's very difficult to answer on behalf of the government. But from academic perspective and what I know based on my involvement in the work and experience, I would like to say that first, the opening of the restaurant and market has not been closed so far. It's open since the very beginning, but to ensure social distancing over there, it's mainly on education, encouragement, and with some other media training, public awareness, rather than administrative measure. But then there is one also, we call it a kind of special measure checked by the health authority for these places, is to ensure that they have the alcohol or gel for hand washing, and they have the fever screening machine at least, and then they are asked or trained in person sometime to take some hygienic measure, like spraying, like for instance in the supermarket the wheelchair has to be sprayed and the place has to be cleaned with detergent regularly, something like that. But for individual physical distancing, I don't think we can guarantee that they have to be more than 1 meter distant, but people were very much aware and afraid, and they were very serious in the very beginning when we had cases. And as I said, market and restaurant have not been closed so far since the very beginning. But in the very beginning, they were very careful. I think they mostly, if not all, wear masks and with their personal hand hygiene. And then every time they go, they don't allow the elderly to go. They don't bring the kid with them. They just go and very quick coming back, you know. And they try to walk a distance from each other. That's what I observe. But we have no particular study or this done, so I cannot say that it's evidence-based, but that's what I can say. The question.
Oh, great.
And the second question is like, when we gonna release all the other lockdown? For instance, I think the big question is the schools. And this is a big question, no one can answer. It's a decision. What I understand from the Ministry of Health press conference, that we look at the situation globally, especially neighboring country. For instance, like in Singapore, there's still a new wave, and then in Thailand, just yesterday and before yesterday, again a new wave. This makes us become worried to release the lockdown or reopen the schools. So then there are also many other reasons that the government said that it's better to continue closed for a while and then see. But there's no very explicit criteria for that, but it's more about a group decision and discussion and careful assessment of the situation around the region, in the region and globally. Thank you.
Our third speaker for today's webinar is Dr. Sarman Singh. He is a professor of microbiology and immunology, and one of the best experts that India has in this field. He is currently the director of and CEO of AIIMS Bhopal, and in the past he has been responsible for lots and lots of diagnostics for several infectious diseases and cancers during his research work that he was doing at AIIMS in Delhi. To you, Sarman Singh ji.
Subhash Hira, thank you very much. And I also take this opportunity to thank and compliment rather Dr. Kaur, that Cambodia is really doing wonderfully well. And I was just looking at, and they have total 122 cases so far and no death. So that is, big compliment to them. And yes, of course, there is a concern that, maybe like he himself said that their markets are open, restaurants are open. So they need to be a little careful that maybe second wave or multiple waves can come. Nevertheless, let us definitely take some clues from them. And I definitely think that between the government of Cambodia and government of India, they will take some of the lessons and how they could do this. Obviously, in the end, I would also like to know from Dr. Kaur, please keep your answer ready. That, I suppose Cambodia, you are having BCG vaccination at the time of birth itself. So because that is also one of the, concern everybody is talking these days, that many of the countries where BCG is given at birth, they are having less of the cases of COVID-19. Now, some of the discussion he had regarding the diagnosis, because obviously no public health can go without the diagnostics. So definitely thank you for that, but definitely I will give a different perspective to the diagnostics. So first of all, I would like to welcome all to AIIMS Bhopal. My greetings, my colleagues, my faculty, my students. They send greetings from AIIMS Bhopal. Now, as we know that from microbiological point of view, it is very important that we should know that what coronavirus is, which causes this, causing this epidemic. So this is a very small, tiny RNA virus, and it belongs to coronaviridae. It has many family members in this, about 39 family members. So many of the people might be thinking that it is something new. No, it is not something new. There are several colleagues or members of the coronaviridae we know of, but of course, this got mutated from the SARS coronavirus. And that's why many of you must be knowing that it is also called as SARS-CoV, that is coronavirus 2. So the coronavirus first is called as SARS because it came mutated from the SARS coronavirus. So that's why it is called SARS coronavirus 2. This is very, very tiny virus, as most of the viruses are, like about 120 nanometer only. Peculiar thing of these coronaviruses, all for that matter, that they are having club-shaped glycoprotein spikes on the envelope, which you can see on the right side of this slide, but I will show you a little more on the next slides. And that is the reason that it is known as crown-like or coronal appearance, and then they are all called as coronaviruses. Now, as I said, that there are about 39 viruses, but I would like your attention here that there are alpha, beta, like here you can see this is alpha family and subfamily. This is called coronaviridae is the family, and then these are the subfamilies. So alpha coronaviridae, then beta coronaviridae, gamma and delta. This coronavirus belongs to this here. You can see here, so SARS and then 2019 coronavirus. So this belongs to subfamily of the coronaviridae, subfamily beta. So this is important, that how many of the people they are having many questions in their mind that from where it came. So it obviously it is very close to the coronaviruses of the bats, and there are many other coronaviruses in various animals. So wild animals, they harbor many types of viruses. One of them are coronaviruses also. So it is important that sometimes whenever I talk, of course today's talk is not on the public health and social changes or environment, but whenever I get opportunity, I also talk on the environment and changing earth. But today is only on diagnostic, but one word definitely I would not leave this opportunity to without saying that obviously the environment is changing and we are destroying our environment, and then probably some of the regions they can be attributed to environmental invasion by the human beings. Now, as I was saying, so here these are the, if you can see, these are the spikes. So these spikes, they are, if you can see, like if you see old kings, so this is crown-like things, it appears. And then here you have the membrane protein, nucleocapsid. Here, this is the RNA, and then there are some other antigens also. They hemagglutinate. So this is important to understand that you might be reading in very social media, newspapers, and many other things that the coronavirus is causing embolism or thrombosis, means coagulation of the blood. So that is also one reason that this is because of this hemagglutinin antigen. So this is also very, very important. And then of course envelope proteins. So these are the very important structures, substructure, even though it is very tiny, but it has many constituents which are very, very important for pathophysiology. Now, of course, topic is diagnostic, but it's also very important that we must understand that how the virus spreads from one person to another. This is a typical dark ground, what we call the microscopic photograph. And then here you can see that once somebody sneezes or even talks, right side this is during the normal talk and left side is a sneezing. So how coughing and sneezing. So how far the nuclei of the droplet which are infected with the virus, these droplets which are usually, as Dr. Poor also said, that they are about 5 nanometer size, and they can reach to any distance about more than 2 feet. But bigger droplets, what we call droplets, which are bigger than 10 micrometers, they settle earlier. So that is the reason that why we call that the people should maintain the physical distance. I don't say social distance, I say physical distance. So we should maintain. So the bigger droplets, they will drop down very close, that within the radius of about 3 to 6 feet. But the finer particles, they can travel little more, and it will also depend how far they can travel. This will depend on the air velocity and the direction of the air. Here also on the right side, if you can see, this is also normally what we talk. Sometimes it is not important that when we sneeze or cough, then only, of course, the quantum is huge, but on the right side, if you can see, this is also normal talking. This was recently about 15 days back. This was also wonderful, video, which is I can show, but it is probably it will not open. So here the normal discussion or talking, what we talk like in normal discussions, there also the droplets be excrete in our voice or in our surrounding. So this is very important, and therefore it becomes important to understand that how the infection spreads from one person to another, and from microbiological point it is very, very important. This is again colored photograph that how it can travel in the when you sneeze or cough and you blast the saliva. So that is very, very important to understand. Now, it is immaterial. It came from the sneezing or coughing or by normal talking. What happens, that how the virus multiplies, that it is important that most of the human beings, we have the this angiotensin converting enzyme receptors. So these receptors, all viruses across every virus, because I'm sure that most of you must be knowing that viruses, they cannot survive on their own. They are non-living, but once they come into contact of the living things, they become live. And for that, these viruses, they must get inside the living mechanism of the body, living machinery. So the what is machinery? Machinery is inside the cells. So by any hook or crook, they must reach inside the cell where machinery is, they generate the things, and they are what we call living mechanics or machinery. So these receptors, these receptors are very, commonly found in all cells, minus RBCs in all cells, particularly epithelial cells. These receptors are very high in quantum, and the most abundant quantity of these receptors are in the endothelium of the lungs, followed by the intestine. And of course, they can be found in any other cells, but not in RBC, fortunately. So what happens that whatsoever, the mode of transmission, but if it comes into contact, which is obviously the respiratory route, so these cells, they start from our nose itself. So from nose onward, the whole of the nasal cavity, nasopharynx, then lungs, all are obviously, all cells, our epithelial cells, they are having a huge number of angiotensin converting enzyme receptors. And these receptors, obviously the virus will go on these receptors because they are abundant in quantity, so the virus need not to search or side away. It will have enough opportunity, so definitely it will get a good number of the receptors. So immediately after receptor, this will invade the cells. Through receptor, it will go inside. It will release its RNA. As I said, it is a RNA. And then, as I said in the beginning, that we have the living mechanism, machinery in our cells. So this will incorporate its own RNA and then start multiplying, because the audience is not a microbiologist. So obviously, I will not give more details. But what happens that it multiplies inside. It converts its RNA into DNA, then again RNA, and then it comes out in the proteins and RNA, they are again synthesized, and this comes out. So what is known as exocytosis. So new viruses, once it is there, millions of viruses, they will come out in the excretion of the infected person. Now, once obviously infection is there, then there can be many consequences. One is, of course, there is an infection and the patient is clinically symptomatic. You will be surprised to know that more than 50% of the patients, even if they are infected, they will not develop any symptoms. So for the public, I don't know if the lay people are listening to this, this is very, very important to understand, and to teach others also that half of the patient, one study carried out in Iceland, and they found that half of the patient, even if they have exposure, they will not develop any a disease, even mildest. Remaining out of the remaining 50%, those who are infected, they might develop very mild disease or just symptoms like which are just body ache or one-day fever. That's all. It will go off, or only coughing for a few days and then it can go away. While the remaining about the 50%, 80% will go into that. Remaining 20%, they will develop little serious disease. So they will have fever, they can have the coughing, and they can have body ache and other things. And then of the 20%, only about 2 to 5% patient, they will go to critical condition. Means critical condition, when we say, then obviously these patients, they will have pulmonary edema or pneumonia. They can have thrombosis, they can have heart attack, they can have GI bleed, they can have various kinds of things. So in X-ray, typical the critical cases, they will have typical findings of the ground glass appearance. So in CT and X-ray, you can find out. So as I said, about 50% and about 80% of the 50%, so about 90% of the patients, even if they are infected, they will recover or they will not develop any disease. Remaining 10%, they will have severe disease, or they might be admitted in the hospitals, or they come for the hospital on their own. But only few patients, they will obviously have the serious condition. And of the about the remaining those who are critical, it depends. Usually it is about 3% people, they will die of the infected and critically sick patients, I am saying. In India, it is the fatality rate is about 4%. In some other countries, it is up to 9 to 20%. But highest is about 20%, and the lowest is less than 1%. Now, laboratory playing rather very, very crucial role in the diagnosis of corona, because as I said, except 3 symptoms, sometimes these symptoms, they can mislead to other things. But most importantly, those who are not having any symptoms, there is no other method by which you can detect the coronavirus infection. So therefore, the laboratory also, they must be very much equipped. And I am really, it was a wonderful that they could cope with in so quickly in Cambodia. They could do it in our country in the beginning, and for that matter, in most of the Southeast Asian countries and Africa. In the beginning, when the testing and screening of these patients started, and I am saying the authority as an administrator of a very big hospital, we were having a real problem, as our honorable member of parliament also, he did mention that, yes, in the beginning, that was in March and first week of April, we were not having the personal protective equipment sufficiently, or if at all, they were very, very poor quality. But fortunately now we have our indigenous products. And therefore, why I am emphasizing that laboratory also, like those who are screening or those who are caring in the nurses, the doctors, the technical staff, those who are in laboratory, they are also equally exposed and they are at risk. And therefore, they also need to have the personal protective equipments for them. Now, then the biggest question is that irrespective the patient was serious or not. So there are in India, I don't know in Cambodia what are the criteria, but in India there were the 3-4 criteria that you have to have travel, international travel in last 10 days. So that was the previously when we started this. And then you should be symptomatic, that these symptoms I said that cough, high grade fever, and then the other some body ache or something like that. And then the third criteria was that you should be symptomatic healthcare worker. Slowly, because in India, Indian Council of Medical Research is the apex body which guides with the Ministry of Health, Government of India in center, that what are the guidelines, how to test, whom to test, and what are the various protocols. And then this protocol was obviously, because international flights were obviously closed in India 24th March onward, is the only test which is available globally and recommended by WHO also. The RNA targets, because you have to have in the PCR also various targets or genes which you want to amplify. To make it more specific, at least 4 genes are targeted, but combination of at least 3 is very, very important. So many companies earlier in the beginning, there was only one company in Germany which started this molecular test, that is RT-PCR. Later on, many companies from other European countries and now in India also they have started. South Korea also started, China also started, now America has also started. So you should have at least the envelope, that is E gene, then nucleocapsid N gene, S gene, 3. These are most important. You can have one of them, either ORF or RDRP. So 3 plus 1 of these. So this is very, very important. So you have to have these 4 gene targets. That is crucial. Now, what sample you should take? Ideally, if you see the bronchoalveolar lavage, which is having highest sensitivity, which is 93%, but by no guideline, bronchoalveolar lavage is advised. The reason being because you have to have bronchoscopy, and obviously bronchoscopy generates huge amount of the the droplets and the chances of contamination of the whole laboratory or the endoscope room. And then of course we have alternative, that is sputum, but you will be surprised that all around the world we are collecting nasopharyngeal swab and throat swabs, but both are having very poor sensitivity. Then recently one company in USA, they also started using saliva, but even after the very recent review I was reviewing day before yesterday, we didn't find any how much sensitivity it has. Also another sample is a stool sample, which has also been shown to have about more than 57% sensitivity. Now, how this sensitivity can be correlated? If you see that in the first peak, it is very, very unlikely of the infection. I'm not saying the symptoms. So after symptoms, this is before symptom, there is very unlikely that the patient will come to you. But in cases of contacts, when we were searching for the people, those who are coming from the international flights or from the other countries and contacts, they were screened. So here, obviously, these were known as contacts. So even though they were not having any symptoms, but they were tested, it was compulsory. So here you can see within 2 days of the infection, the PCR can become positive if you are using nasopharyngeal swab for PCR. And of course, you can also isolate the virus. So these 3 tests, and of course, as I said, bronchoalveolar lavage nobody is doing as a standard, but if you are doing with the controlled condition, of course, that will have the same kind of detection. So either the nasopharyngeal swab or the virus isolation for doing from the same swab, you can have either by PCR or by isolation. And then of course, after symptoms, the patient who is symptomatic, you will have all these 3 possibilities. You can isolate the virus in the culture, or you can amplify its genes using any RT-PCR. Now, after that, what happens that after 2nd week or so, this may be a controversial because in south of the Korea and China, some cases were reported, but later on it was found that they were the remaining genetic material, as Dr. Kaur also said, that genetic material actually not the reinfection. So they were found to be not reinfection or reactivation, but the genetic material, which was false, you can say false positive RT-PCR. So that remained. I am not covering this antibody. I will come later on the part of my presentation. So here, the point is that if you are searching for the contacts, of course, these molecular tests are good, but if symptoms are there, then also they are good. So first after infection up to 14 days or so, they will be really very good and high sensitivity. So time of sampling is very important, Dr. Kaur also said, and I am again re-emphasizing. Now, various companies, as I said in the beginning, this was a European company, but again, it was a huge burden on the European companies because they themselves, they were having a lot of demand and they were not able to supply the kits. And then, thanks to China and Korea, nowadays, if you see that most of the kits, they are being supplied by these two countries, China and South Korea. And these, they are having obviously at least the three, genes, and they can also detect the other viruses. So they are single tube tests. They have come up recently, and they have seen earlier, as I said, that you have to have at least RDRP is a must, and you have to have at least 3 genes, but they are having 2 genes only. And they say that, it is equally good. So now you can have these kits available in the market. Now, this slide, I think it is very, very important that if you see that what sample you are taking, if you are taking respiratory samples, or you are taking a stool sample or serum, these are the 3 samples you can think of. Urine, nobody has as yet tried, and it is also not expected, but definitely these 3 samples, they are known to be used. And if you see that they can remain positive respiratory sample up to 40 days, if you can see here, but average is about 18 days. Similarly, here also stool can remain positive up to 60 days. So that is something one has to understand. And then many times this is very important that clinicians also, or those who are program managers, they must understand. So these slides are, I think, very, very important. So again, then if you sub-analyze these samples according to the condition of the patient, then you will realize that even in the respiratory sample, which is, remain positive, but if you see the patient is having mild symptoms or severe symptoms, and here you can see the severe symptoms, obviously, they will have many, many days to remain positive, and they will be highly positive. In mild, obviously, this will be very few days only, and they will, obviously, they will heal the infection. Same is here in a stool sample and also in the sputum sample. So this is very, very important, because the mild samples, what we say, mild symptomatic or asymptomatic, they will clear the virus spontaneously very quickly. But severe cases, obviously, because it has already, the pathology has set in the lungs. So obviously this pathological, until otherwise, these epithelial cells, they will continue to set off. And then with the cells of the epithelium, they will continue to excrete the virus in their samples. That will continue. Similarly, viral load, if you see in the 3 samples, the highest viral load will be obviously in the respiratory samples. Very undetectable, we can say, but undetectable levels of the virus will be found in the serum. Again, if you see in the same way, as I said in the previous slide, here also, obviously, the severely diseased or having multiple manifestations or complications, particularly the pulmonary pneumonia, or those who are having thrombosis or something like that, or those who are on the oxygen support, they will obviously have huge number of the viral load, which is very, very important. And the others, they will have very low load, and sometimes they can be they cannot be detected because the viral load is very low. And then again, from severe to mild, how from days to they usually they go down, and then they develop the viral load goes down from severe to mild, and then the asymptomatic, or when they recover from the disease. So obviously viral load plays very, very important role. Now, these days, many times this slide I put because many times many people, they ask that what is the cutoff limit of the viruses or virion, what we call which can be detected in most of the RT-PCR which are available these days. These days, quantitative RT-PCR have become available, but in India, I don't know, in Cambodia, but some companies in China and some companies in South Korea, They are exporting to European countries, I am aware of. So, but in India, we don't have as yet, because we are struggling with the diagnostics. We are not bothered about the quantitative viral load issues. But now, because we are doing some clinical trials, so for these clinical trials, obviously we need this quantitative RT-PCR kits. So now we do have that. These companies, like Takara is one company, they claim that they can have as low as 5 viral copies per reaction. So in one tube, you have to have at least 5 viruses or viral, RNA that can be detected. Usually, right now, most of the kits, they are having 50. So 50 viral, particles in a reaction tube. That is usually standard. Most of the kits they are having, but as I said, now we are having better kits available. Now, other than RT-PCR, one can think of, or one can, discuss. That is recently, very, very recently, I can say in India, only last week, the government of India imported the cartridges of the CFID. I am sure that most of you must be knowing that those who are working on tuberculosis and HIV, they must be knowing that CFID has been known as a game changer, which in tuberculosis made a big, change in the diagnostics and detection of the rifampicin resistance. The same company came for the HIV, hepatitis C, and hepatitis B virus detection. But here, now recently, they have come up with the Expert Express, what they call, and this is for the COVID-19 detection. This is sensitive to be compared in our laboratory, and we found that the concordance, what we call, is 100% with the RT-PCR. So this is the beauty of this is in tuberculosis also, and same thing is here for the coronavirus, that the sample processing is inbuilt in this. So that is very, very important, and that makes it different, and probably this may be the very quickest. The RT-PCR usually, because you have to have RNA extraction separately, which takes huge time, sometimes a few hours, and then of course you have at least 90 minutes or so reaction in the RT-PCR. So overall it takes about 5 to 6 hours, but this can give you result in 30 minutes, so including sample preparation and everything. In 1 hour maximum you can give results. This probably, but of course, like RT-PCR, you cannot run many tests. In most of the laboratories, we are having 4 modules. So you can run 4 samples, or 4 times or 6 times you can run. So about 24 to 30 per day. So Government of India now is going for the using this Gene Expert machine. Machine is same, cartridges are different, to diagnose coronavirus infections in the district level. And they are taking this opportunity to pitch in with the expert machines every district in India is having for tuberculosis. So only cartridge will be different, but the same machine can be used at every district. So now, today itself, our Honorable Minister of Health, Union Minister of Health and Family Welfare, he discussed and he declared that from next week or so, all districts, they have this facility to diagnose coronavirus infection using these CPID cartridges. Now, even if we have discussed a lot about the what genes and other things, but it is very important that how to interpret the test and what are the points of caution. That obviously, as I said, that in RT-PCR, those I don't know, so I will not give much emphasis because probably you are not from the molecular background, but the CT value is more important. So on the basis of CT value, tests are reported positive or negative. And as I said earlier, some of the slides, mild cases, they have obviously higher CT value, and the severe cases, because they are having more viruses in their samples, they will have lower CT value. And then, of course, usually you have to have, within 48 hours to 3 weeks, as already showed to you, so they will remain positive. And important thing is that if you recollect my previous slides, RT-PCR positivity does not necessarily indicate replicating virus, because recently there was a publication in JAMA. They said that even if RT-PCR positive cases, in no case they could isolate, means culture the virus after 9 days. So all the viruses, even if there is an infection, this will become, of course, after resolution of the symptoms, it will remain unculturable, but of course RNA you can detect. So that is not necessary that RT-PCR is positive means it is multiplying inside the body. Similar is also true that RT-PCR negative does not rule out that the patient or the person is not having infection. As I said, in most of the situations we take nasopharyngeal swab or throat swab, which I showed to you that they are having very less sensitivity. So it is very, very important to understand. Then again, there are whether the sample was taken appropriately or not, and then what was the viral load at that time, and then it can remain up to 3 weeks, and then of course sometimes it has also been seen that one day in my experience we have seen that one day RT-PCR was negative, second day it became positive. So next slide probably show you that how it happens. Now survivability is very, very important. That this I already told to you that after 8th day of infection, very unlikely you will find that the virus is culturable, means it is not multiplying. And that is the probably reason that government of India and many of the governments like UK government earlier also decided that after 10th day of the infection, the patient may be allowed to go. And then very recently, yesterday only, government of India also decided that those who are mildly symptomatic and then after recovery of their symptoms, if they don't have any symptoms and they have been in the hospital for 10 days, they can be allowed to go back. Even you may or may not test them. So without testing, this is the presumption of the government and the task force of the government that after 10th day, the virus will not be culturable and it cannot transmit to others. So that is very significant finding, and this was published recently in JAMA. So now to my earlier, I said that I will show you the slides. So if you see here in this slide, you will very interestingly, you will find that the same patient sometimes is coming positive and negative. So one day it is coming positive and next day it is coming negative. So why it happens? Because it is intermittently it is shedding in these samples. So this becomes very crucial, and for all laboratory physicians and of course our treating physicians, they will may or may not understand, but for laboratory physicians, it is very important to understand that it is an intermittent shedding in the sample. So it is quite possible. You need not to be disheartened that no, yesterday it was. Understand and explain that how it happens, and it is common. It is nothing wrong in that. Of course, it will add if your sampling error is also there, then that is another factor. But as such, even if the controlled samples are taken 2 days or 3 days, you will find differences in the shedding of the virus positivity. Now, little bit about the rapid antibody-based test for the diagnosis. I call it, and very recently I published an editorial, I think it is a bigger epidemic of unscientific practice. Why I am saying? Because the antibodies, as Dr. Kaur also said, that antibodies, many countries, they started, particularly the China and Korea. But government of India bought several thousands and thousands of the kits with the aim that they will be used for the sero surveillance only. Underline, sero surveillance only, not for diagnosis. The purpose is different for antibody test. For epidemiological purposes, for the public health point of view, it is very important they can be used, but only in low endemic areas where you want to say that if there is any unknown or hidden case, in those cases. But what happened in India, on the urgent basis, the government of India allowed the import of these kits. And you will be surprised that in India, our corporates and the illegal marketeers, they brought thousands and thousands of these kits. So government banned it, but still in Indian markets, they are still there. and people are misusing these, just like they did in the cases of tuberculosis. They were using serodiagnostic for TB. So that happens. Definitely the antibody test, they are no, big no for the diagnostic, of course, not for prognosis. So diagnosis and prognosis, no, big no for the coronavirus, but of course, only utility is for serosurveillances. Now, why I am saying so? Because the reason is that if we say that this is important, because if you see the IgM and IgG, which are the antibodies which we see in these antibody tests, very recently, this study was last to last day only, I took it. So if you see that in the first week, only 27% patients, they will be positive by antibody test if you do. And these are all RT-PCR positive. And here IgG, which is another antibody, most of the ICT rapid test or POC kits, what we say. So this will be only 3.3%. And so first week overall, because the kits, they have IgG and IgM both. So combinedly, the kit will be able to detect only 28% of the cases if you are testing the blood in the first week of the symptoms here. These are the symptoms. Second week, little bit better, half of the cases you will detect, but actual utility comes only after 2 weeks. So this is very, very important, and therefore it is important that they should be used for only surveillance. By this time, the patient has become already aviral. So there is no virus in the sample anywhere. So this should be used only and only for surveillance purposes, that how many of our patients got infected and cured. So that is the only purpose they should be used. And why, again, the previous slide I said to you that the appearance of, you see the IgG here, this is a detection here, this is a window period, you will not be able to, so this is asymptomatic stage, you will not be able to. The detection level will be somewhere here only. So this you will come in 14 days to 21 days, and even the IgG you will get in convalescent type period. So this is the only period which is by that time, the virus, as I said, if you remember, I said after 10th day, there will be no virus replication. So
there is a question from Rajat Lodha of Dehradun, and he is talking about people who get reinfected and if they should be quarantined after they have been detected as reinfected. Now, let me explain what he is trying to indicate in by terms of reinfection. It's a reinfection is that somebody who was tested COVID positive by the PCR test was then treated, and then after 14 days or whatever period, he was then retested and found to be negative on RT-PCR on two times at 2 days apart, and then was discharged. And then probably an individual comes back for some reason and then found RT-PCR positive again, and that started to get labeled as reinfection. Wuhan categorically made statement that there was no such reinfection happening in China. As a result, this issue of reinvention is now being kept aside. But the question Rajat Lodha is asking is that if somebody comes again tested positive, should he or she be quarantined again?
No, as I said, because these are the practical questions. That's why I put some of the slides, because this kind of questions they were coming up repeatedly in our routine system. And these are, as I said, that earlier there were some reports that in China they got some infections. They called it the reinfections, but actually they were not the reinfections. This was false positive PCR. So once the virus has gone away, means the spontaneous cure, or obviously there are no specific treatment. So once there is a spontaneous cure, it is no reinfection. There is no report, authentic report. So this is false sense of phobia, and this was false positivity of the PCR, as I showed to my presentation. that these were actually the PCR, issues which I wanted to clarify. Many times, because what this question is, many people they ask this question, they were actually not reinfection, neither the reinfection nor the relapses. There is no relapse report. There is no infection report so far. Authentic.
Thank you, Dr. Sarman Singh ji, for an excellent lecture. Very, very distinctly clear and useful. There is a quick question from Jane, one of our African participants, asking about gene expert tests for COVID-19 that you just mentioned having 100% agreement with RT-PCR. Are these COVID-19 diagnostic cartridges available for Africa from the company?
Yeah, so right now this gene expert is being imported by government of India. I'm sure your government also, because personally, because it is all RT-PCR, whether it is RT-PCR or gene expert, they are a huge demand. So they are the own priority. WHO and government of every country, they have the priorities. So what happens? These prioritized imports, we have the first priority and supplying to you. So you ask your government, definitely they will be, because in the whole of the African countries, there are huge number of the experts I know for tuberculosis.
Okay. The ISRN delegates from Northeast, Tripura, Manipur, Sikkim, and others, they have informed on the comments that the northeast of India has been kept COVID-free with a lot of effort that our colleagues are doing on the field in the northeast, and they are asking us to acknowledge the success of keeping northeast of India as COVID-free.
Yeah, definitely. Compliments to, I know, Arunachal and Sikkim and all the Nagaland, all these territories, they are having COVID-free. They are, and my wholehearted compliments to them.
So congratulations to our colleagues and our participants from Northeast. So as we finish this third webinar, I wish to remind you about the fourth webinar on 19th May. It will be Tuesday, the same time, and it's titled Treatment of COVID-19 and Convalescent Plasma Therapy by two accomplished doctors and vaccine development by a virology specialist of Pittsburgh University, USA. So we maintain a true character of global COVID network and keep participants also from all across the globe. I thank all the panelists today for wonderful talks, as well as the Secretariat at Sambodhi, especially Camilla and Anubrata, for dedicated work. The microlight link that is set up and functional on Sambodhi website, it is functional repository of all the webinars and lot of published material in that field. So most welcome to visit the microsite and use it whenever you have time.
Thank you so much. Thank you so much, Dr. Hira. Thank you so much, panelists, for joining us. I just, before we close the webinar for today, I'd like to thank our participants and attendees for their patience. We did overshoot, but I guess the nature and the content of the webinar was so rich that I'm sure they didn't mind. I'd also just like to announce that we have launched the Global COVID-19 Network microsite. I will share the link with all participants and with our mailing list shortly. And I invite you to explore the microsite and share it with the larger audience so that we can help research and help action activities against COVID-19 in the global south. And please do find the webinar recordings and summaries as well as the slides from our speakers on the microsite, and help us in spreading the message of the network across the globe. Thank you so much, and we look forward to your participation over the coming webinars as well.
Thank you, the Secretariat, and thank you, Dr. Sarman Singh and Dr. Paul.
Thank you. Thank you.
Great. I think we'll catch up on other fora. So it's a good night from us.
Yeah. Good
Thank
night.
you
Good
again.
night. Good night. Good night.
Bye-bye.